we are going to talk about investigations that we do for ear problems. Right now we are only going to discuss investigations for ear. Nose and throat we will discuss later on. Now we know that ear is divided into, has two functions. One is hearing and one is for balancing. And on the same basis we have divided the test for ear into two parts. One of them is hearing test, that checks the cochlea, basically the hearing part of the ear, and the second one that checks the balancing is called the vestibular function test. We all know balancing is done by the vestibule, so the tests are called vestibular function. So hearing test, vestibular function test, and each of them can be divided into clinical and laboratory test. Similarly, vestibule can be divided into clinical as well as lab test. Now in the clinical test for hearing, the only important test is tuning fork test. This is perhaps the only important one, but lab test for hearing, there are a couple of them, like audiometry is very important, tympanometry, BERA, we'll talk about the full form a bit later, auto acoustic emission short OAE, and electrocochleography. Okay, these are some of the important tests for hearing. And which are the main vestibular function tests which are of clinical in nature? A very important one is the caloric test, you can do fistula test, and things like Romberg's, Unterberger's, these kind of tests. And which are the main lab tests for checking the vestibule? We have electrocochleography. This one is pretty important. Electronystagmography. Optokinetic test. Galvanic test. Posturography. VEMP, vestibular evoked myogenic potential. These are some of the important types of. I'll write the names, don't worry again. Okay, so we have clinical hearing test, we have lab based hearing test, we have clinical vestibular test, and we have lab based vestibular test. If I have to pick one name of the list, it has to be the tuning fork test. Tuning fork test is very important, very commonly asked in the exam, and it is slightly concept based. Okay, and so you have to know it properly. Now before I talk about tuning fork test, you have to know the difference between air conduction and bone conduction. AC in short and BC is for air conduction, bone conduction, and you also have to know the difference between conductive hearing loss CHL versus sensory neural hearing loss. Now you have to know the concept of these two things, ACBC versus and CHL versus SNHL. Now let me draw this diagram that I keep drawing. Pinna, canal, tympanic membrane, middle ear with three ossicles. I draw three dots. Inner ear, cochlea. Eighth nerve carries the signal to the brain. The hearing part is the cortex where we finally hear the sound. We know this by now. So this is the entire hearing pathway. In this hearing pathway, we have pinna, canal, tympanic membrane, middle ear, ossicles, inner ear, nerve, brain, which is the most important thing for hearing. I can easily say that the most important thing for hearing is the sensory organ of hearing, organ of corti. Where is it located? In the cochlea. So this is the cochlea. Let's assume that this red thing is the organ of corti. Just assuming. Sensory organ of hearing. What it means is that for hearing, you must be able to send the sound to this organ of corti. If you can send the sound to this organ of corti, rest will happen by default automatically, and the sound will reach the brain and the patient hear. We must be able to send the sound to this organ of corti. And sending the sound to the organ of corti, you have two pathways. One is air conduction pathway, AC. The other is a bony conduction pathway, BC. Now what is the basic difference? Now suppose this pen is the tuning fork. You strike it, it begins to vibrate. How do you check the air conduction? AC. You place the tuning fork outside the pinna here to check the air conduction, isn't it? And how do you check the bony conduction? The base of the tuning fork is placed on the mastoid bone, mastoid. So the sound travels through the mastoid bone and you can hear. AC, BC, we know this. That means during air conduction, the tuning fork is outside the pinna. In this diagram, let's say this is your tuning fork, outside the pinna, and it is vibrating and producing sound. So how is this sound from this tuning fork going to reach the brain so that one can hear this sound? It's pretty logical, we have discussed this already. The sound of this tuning fork is first going to travel through the pinna, then through this canal, then through the tympanic membrane, and then middle ear and the ossicles, and finally goes to the organ of Cotta in the cochlea. And from here the sound travels through the 8th nerve to the brain, where you finally hear the sound. And we discussed this already. The important thing to realize here is that during air conduction, every part of the ear is used. Every part means pinna is used, canal is used, tympanic membrane, middle ear and ossicles, inner ear, nerve, brain, everything is used for air conduction, AC. And therefore, problem to any part of the ear is going to affect the air conduction. So no matter where the problem is, AC will always have a problem because AC is using everything. But during bone conduction, the tuning fork is placed on the mastoid bone here. And the sound from the mastoid goes directly inside the cochlea. So from the bone, the sound goes directly to the cochlea inside, and from there it travels to the nerve and the brain, and you hear a sound in the brain. This is bony conduction, where we use only this much. We do not use this much, right? Whereas in air conduction, we use everything. What it means is that if there is a disease in the external and the middle ear, if the disease is in this part of the ear, only AC should be affected, BC should not be affected, because BC is not using this part. Whereas when the disease affects this part of the ear, inner ear, nerve and brain, then both AC and BC should be affected because this part is used by both AC and BC, isn't it? That's the logic thing. So the blue marked area, only AC should be affected, and the green marked area, AC and BC both should get affected because both are using this part. Based on this, we have divided hearing loss into two types. If this part is involved, which is the external and the middle ear mainly, it is a conductive pathway. So it's called conductive hearing loss, in short CHL. Okay, so CHL stands for conductive hearing loss. And if this area is involved, affected, which is used by both AC and BC, then you have the sensory organ and the neural part. So it's called sensory neural hearing loss, SNHL in short, sensory neural hearing loss. This is how we divide the hearing loss into two main types, conductive hearing loss and sensory neural hearing loss, right? Now in sensory neural hearing loss, what is affected? In sensory neural hearing loss, we have the problems either in the sensory organ, which is cochlea, or the neural path, which is the 8th nerve. That's why sensory neural hearing loss is further divided into two types. Sensory neural hearing loss means either there is a cochlear disease, sensory organ, or the nerve is disease, neural path, sensory neural. So that's why it is divided into two types. When it is the cochlea which is damaged, it's called cochlear disease. Cochlea is damaged, cochlear disease. And if the nerve is damaged, which is after the cochlea, it is called retrocochlear disease. This term I told you before also is a very important term, right? So we have a cochlear disease and a retrocochlear disease. Both are subdivisions of sensory neural hearing loss. So hearing loss is divided first into conductive and sensory neural, and sensory neural is further divided into cochlear and retrocochlear diseases, right? So I told you already that we are going to discuss mainly the tuning fork test. Now tell me, which is the most commonly used frequency during a tuning fork test? We all know this is a very simple question, but it's kind of asked pretty commonly, and the answer is 512 Hz. The most commonly used frequency in a tuning fork is 512 Hz. We don't use lower frequency than this commonly, and we don't use higher frequency than this commonly. Why? If you use a lower frequency, which is 256, then it vibrates too much. So when you place it especially on the mastoid to check the bony conduction, you can feel the vibration. See, normally you should not feel the vibration, you should hear the sound that is produced by the vibration. Difference. You must be able to hear the sound but should not feel the vibration. In lower frequencies, we can feel the vibration also. So sometimes there is no sound, you can't hear the sound, but you can feel the vibration and you confuse, you think it is a sound you hear. So it creates confusion because you can feel. So feel is the word. And if you use the higher frequency which is 1024, so when you strike it, it vibrates for a very short duration of time. You strike it, vibrates very short, it dies, it stops vibrating. So before you have put it here or here, it stops vibrating. So again and again you have to do repeatedly, So we use the word it dies very soon or it vibrates very short duration of time. So it is a cumbersome thing. Low frequency, you can feel the vibration. High frequency, it dies very soon, doesn't vibrate enough. So the 512 is the best option. Now what are the important types of tuning fork test? Tuning fork test can be of many types, but these are few important names that you have to remember. Everybody has heard the name of Renes, Weber's, ABC, which is very similar to Swabax. Binge is another important name, Galleys. Okay, then other like Binge autotoxic drug test, Stenger's test, Simony-Moyes test. So you can remember the names of many tuning fork tests, but essentially the first three. These are the three that they ask you in the exam most commonly: Renes, Weber's, and Swabax, which is sometimes called absolute bone conduction. They are not sometimes, they are different. There is a difference between Swabax and ABC, but they are very similar tests. So we include them in the same group. Now what is the difference between these three? How do you do Renes? How do you do Weber's? How do you do Swabax? In a Renes test, let's talk about Renes test. In a Renes, suppose this is the tuning fork, you strike it, it begins to vibrate. In a Renes, you check AC and then you check BC. AC, BC, and you ask the patient to compare the two. So what you say is, in Renes, AC is compared with BC. Comparison is done in 1 ear at a time. So once you have done Renes in this side, you may or may not do the Renes on the other side. Weber's. In Weber's, the tuning fork base is placed in the center on the bone. This area usually, this is called the vertex. So we place on the vertex most commonly. You can place anywhere, but vertex is the most common area. So that it is in the center, so equal bony conduction will happen in both the ear. And you can compare the bony conduction of the right ear with the bony conduction in the left ear. So this is what is done in Weber's. Right ear BC is compared with left ear BC. There is no AC this time. What is done? BC of the two ears are compared amongst each other. This is Weber's. And what is done is Swabax, which is sometimes called ABC, very similar. In Swabax, the tuning fork, which is vibrating, is placed on the mastoid bone of the patient and then on your bone. Patient's mastoid, bony conduction, and your own bony conduction. So patient's bony conduction is compared with the examiner's bony conduction, assuming that the examiner's hearing is normal. So you are assuming that your is normal, and you are comparing patient's hearing with your hearing. This is Swabax. Okay. So Renes, AC is compared with BC. Weber's right ear BC is compared with the left ear BC, and ABC or Swabax, patient's bony conduction is compared with the examiner's bony conduction, assuming that the examiner's hearing is normal. Now, when you check AC, when you do Renes, AC is compared with BC, you do AC and BC, and you ask the patient which one is louder. Some may feel AC is better. We write like this: AC is better or more than BC. Some may feel BC is more, so we write like this: BC is more than AC. Obviously, if you are going to compare two things, one has to be better. Some will feel this is better, some will feel this is better. Either AC is better or BC is better. If AC is better, it's called positive Renes. If BC is better, it's called negative Renes. So Renes can be positive or negative, and each can further be divided into true positive readings and false positive readings. Similarly, Weber's can be true negative can be true negative and false negative. Now we have 4 situations in tuning fork test: true positive, false positive, true negative, false negative. When you get true positive readings, when the hearing is normal. So when the hearing of the patient is normal, if you do a readings, you get a true positive readings. False positive, if the patient has sensory neural hearing loss. SNHL stands for sensory neural. That means if you get positive readings, AC is more than BC, you are not sure. It could be normal or it could be SNHL. If it is normal, it is true. If it is SNHL, it is false. Okay. And similarly, when you get true negative reading, CHL, conductive hearing loss, and false negative, dead ear. When the ear is completely gone, hearing is 0. Dead ear is usually when we have a severe SNHL. Okay. Once again, if you have negative readings, which is BC more than AC, you are not sure is it CHL or is it dead ear, which is completely gone, severe SNHL. Okay. So true positive is normal, false positive is SNHL, true negative is CHL, and false negative is severe SNHL. Now what it tells us is that if you do a readings and if you get a true positive readings, you know it is positive, but you don't know whether it is true or false. You're not sure it is SNHL or normal. Similarly, if you get a negative readings, you don't know it is true or false, so you don't know it is CHL or severe SNHL. That means by doing a readings, it does not give you a complete picture, complete information. And that's why we may have to do Weber's, where we have to place it here, bony conduction, so that the patient can compare the two sides, and we ask the patient which side is better or louder. Some patient feels this is better, I can hear this one better. Some feels I hear better in this side, and the others who might feel it is equal on both the sides, equal. When it is equal on both the sides, we call it centralized Weber's. So I'm writing here, centralized Weber's. So when I say centralized Weber's, means the patient is hearing equally on both the sides. But if the patient hears one side more than the other, we call it lateralized Weber's. Okay, so Weber's is either centralized or lateralized. How do you show in a chart? In a chart, we draw like this. Suppose this is the right side and this is the left side. Okay. And between the two, we draw a line like this. Let me remove this. Between the two, we have to draw a line like this. Like this. And if the patient says that I hear equal on both the sides, you have to draw arrow on both the sides. If you have drawn like this, arrow on both the sides, right and left, you know that it is centralized Weber's. You don't have to write centralized now. If the patient says I hear on the left ear only, not in the right side, then you draw the arrow like this on the left side. This is lateralized to the left side. And if the patient says I hear on the right side, you draw arrow on the right side. This is lateralized to the right side. Now the first arrow is centralized, second is lateralized to the left side, and third one is lateralized to the right side. So Weber's is either centralized or lateralized. Now when is it centralized? Now this is not 100% true, but for practical purposes, centralized Weber's is seen when both sides are normal. That means right is normal and left is also normal. Both sides are normal, then and only then you get centralized Weber's. So if you do a Weber's and the patient says I hear equally in both the sides, you can say with all confidence that both your ear have equal normal hearing, and that's why you're getting a centralized Weber's. But when do we get a lateralized Weber's? Lateralized Weber's is seen in conductive hearing loss as well as in sensory neural hearing loss. Conductive as well as sensory hearing loss, both will give us a lateralized Weber's. Now this is very important. In SNHL, Weber's is lateralized to the opposite side. So if you have SNHL on this side, Weber's will go to this side. If you have SNHL on this side, Weber's will go to this side. So in SNHL, Weber's gets lateralized to the opposite side, and in CHL, Weber's gets lateralized to the same side. This is very important. In SNHL, Weber's goes to the opposite side. In CHL, Weber's goes to the same side. Right? Very, very important. Now, what does it mean? That in this case, if it is SNHL in the first one, which side? SNHL. It is this side. SNHL. Yes or no? That's why Weber's is going to the other side. In SNHL, Weber's goes to the opposite side. In the next one, last one, if it is SNHL, which side? It is this side. Again, we understand. In SNHL, as we see in both days, Weber's goes to the opposite side. If it is CHL in the first one, which side? Same side. In CHL, Weber's goes to the same side as the arrow. So CHL has to be this side. This is the CHL, same side as arrow. In the next one, if it is CHL, which side? It is this side. So notice, in CHL, the arrow is on the same side. In SNHL, the opposite on the arrow is on the opposite side. So CHL same side, SNHL opposite side, and centralized if it is normal on both sides. Now, what does it mean? If I tell you that I know a patient where I do Weber's, this is the right side and this is the left side. Okay, I know a patient where I have done the Weber's and this is the result. It is going to the left side. Now, what is your answer? What is the problem in this patient? Let me create some space here. I'll come to this question once again. Now, what I'm going to tell you now is actually the most important thing to understand in a tuning fork test. If you understand the meaning of this, what I'm going to tell you now, then tuning fork becomes very easy to understand and crack. And it's very simple actually. Now, this is the right ear, this is the left ear. I do a Weber's, I get this side, Weber's going to the left side. Now, what is the problem in this patient? It means maybe this side is normal, maybe. If this is normal, this has to be CHL. Now, somebody who has the combination of right normal and left CHL, if you do Weber's, Weber's will go to the left side because left in CHL, Weber's goes to the same side. In this case, left side. If this one is normal, then this has to be SNHL because SNHL Weber's goes to the opposite side. Now, whether it is this combination in the first one or this combination in the second one, in both the cases the Weber's will go to the left side, right? Or both. This is SNHL plus this side is CHL. If you do Weber's in this, again it will go to the left side. Or if this one is more SNHL and this one is less SNHL, again Weber's will go to the left side because in SNHL it goes to the better side. And if this is less CHL and this one is more CHL, Weber's will go to the left side. So whether it is this situation, combination, or this combination, or this combination, or this combination, or this combination, any of the 5 combinations, Weber's will only go to the left side. And pretty logical. So this is what it means by lateralized Weber's. When I say lateralized Weber's, what is the meaning of that? It means the patient is having one of the 5 things, combinations. Which one? You don't know. You can't predict. It is one of the 5, but you are not sure which one. Remember in Renes, if you get positive Renes, it is either normal or SNHL, you're not sure. Similarly, Weber's also does not give you a confirmation. If it is centralized Weber's, then by and large you know that both are normal. But if it is lateralized Weber's, then it is one of the 5. Which one? You are not sure. It means alone Renes does not give you all the information. Alone Weber's, it does not give you all the information. And that's why every time you do a tuning fork test, you have to do both Renes as well as Weber's. And when you do Renes and Weber's, have a result of both, like a basic mathematics, you can deduce the correct answer. Right? So Renes and Weber's are always done together. But sometimes having done both of them, you still cannot be sure. There is a doubt left. In those cases, we do Swabax test. So Swabax is not done commonly. It is done only when Rennes and Webers fail to give you a confirmation. So once again, if it is centralized Webers, both sides are by and large normal. If it is lateralized Webers, either it is CHL on the same side or SNHL on the opposite side, right? In SNHL, Webers goes to the opposite side. In CHL, Webers goes to the same side, right? And like I told you, that sometimes having done Rennes and Webers, you still have a doubt. In those cases, you have to do Swabax, where the patient's bony conduction is compared with the examiner's bony conduction, assuming that the examiner is normal. So when you compare patient and examiner, the patient might feel that his hearing is same as you, equal hearing. So we write equal hearing in patient and examiner, which is shown with an arrow like this. Small arrow, equal hearing. Or patient might feel that his hearing is less than you, which is shown like this, less than you. Or patient might say that his hearing is more than you, which is like this, right? So patient's hearing is either less than you or more than you or equal to you, one of the three things. When is patient's hearing equal to you? You are normal, assumed, and patient has equal to you, patient must be normal. So if patient's hearing is equal to you, then patient's hearing is normal. That's why it is equal to you. When is patient's hearing less than you? When the patient has SNHL, sensory neural hearing loss. And when is patient's hearing better than you, more than you? When the patient has CHL. If you remember, we are comparing bony conduction. In CHL, bony conduction goes to the same side. So patient has more CHL, that's why patient hears bony conduction better than the examiner. So equal to you, patient is normal, less than you, patient has SNHL, more than you, patient has CHL. Now there are two very important things here. In Rennes, there are two options, either positive Rennes or negative Rennes. In Webers, there are two options, either centralized Webers or lateralized Webers. But here we have three options, either equal or less than you or more than you, right? Now second thing, in Rennes you are not sure. If it is positive Rennes, either normal or SNHL. If it is negative Rennes, either CHL or dead ear. Webers also you are not sure. If it is centralized Webers, you are sure both are normal. But if lateralized Webers, is it same side CHL or opposite side SNHL or both? The five options like this one. But in Swabax, there is only one option for each of them. Equal means the only option is normal, no other options. If the patient's hearing is less than you, the only possibility is patient has SNHL. And the patient's hearing is more than you, then the only option is patient has CHL. There is no either this or that. Meaning, the Swabax will always give you a confirmation, isn't it? That means if I ask you to do one tuning for test and give me a confirmation, which one do you do? Swabax test. It will always give you a confirmation. There is no dilemma here. Now my question is different. If Swabax is such a good test, which always gives you a confirmation, then where is the need for Rennes and Webers? Why do we do a Rennes and Webers? We should abolish all other tests, only concentrate on Swabax that always give you a confirmation. In fact, we don't do the Swabax in the as a first test. We only do Swabax when the Rennes and Webers leave some doubt. After doing Rennes and Webers, we are not sure, only then we do Swabax. Why this? A very important thing, that Swabax, we have assumed something. We have assumed that the examiner is, मान के चलते कि the examiner normal है. And maybe that is not true, the assumption is not true, you know. So because we assume something in this, it loses its scientific credibility. It's not a credible test. It's the best test. It's not a credible test. Credibility नहीं है क्योंकि मान के चलते हैं, you know. That's why it is not the first line of investigation. It is a third, maybe Rennes, Webers, and if it is required, then you do Swabax. Right. So we'll talk about these, and then about masking. When you're tuning for test, you may have to do masking also. Now during AC testing, The masking is required when the threshold of the sound hearing is more than 40 decibel. What is threshold? We'll know when we talk about audiometry. But remember that if the threshold of hearing of the patient is more than 40 decibel, then you have to do what is called the masking. In AC, this is for AC. And when is masking done for BC? During BC testing, masking is required when the threshold is more than 5 decibel. Right? That means in a bony conduction, masking should always be done. 5 decibel hearing loss to hoga hi. It will be always be there. So masking is practically always required for bony conduction. Now this tells us something very important. That bony conduction can detect hearing loss as little as 5 decibel. You know, even if the hearing loss is 5 decibel only, bony conduction can detect that. But AC, air conduction, cannot detect hearing loss which is less than 15 decibel. So if you want to do a tuning fork test or AC basically, then the hearing loss must be more than 15 to 20 decibel. But if you want to do BC, 5 decibel will be detected. So which is the more sensitive tuning fork test? BC is the most sensitive tuning fork test, and Weber's we do only BC. Remember, right here BC is compared with left here BC. So if I ask you Rinne's and Weber's which is more sensitive, Weber's is more sensitive because it is checking the BC, and BC can detect as little as 5 decibel hearing loss. Right? Few points about other tests like binge. Binge and Galleys. For Galleys test, you have to use an instrument called Siegel's speculum. If you want to do a Galleys test, you have to use a Siegel's speculum. And the result of binge is similar to the result of AC, that means of Rinne's. If binge is positive, it is normal or SNHL. If binge is negative, it is CHL, similar to Rinne's. Now there is one very important point, that binge, if it is negative, if binge is negative, it is taken diagnostic of autosclerosis. Although always it is not true, but this is what you have to know. You have to know this, that negative binge is autosclerosis. So let's talk about 1 or 2 points more about this tuning fork. You have to remember all these names that I have given. Just remember that Galleys test, you have to use what is called Siegel's speculum. We'll talk about this speculum later on. I'll show you the diagram also, a picture actually. But for Galleys test, you have to use Siegel's, and the result of Galleys is interpreted similar to Rinne's. Remember, Rinne's positive is normal or SNHL and negative is CHL. Galleys is also interpreted similarly. But there is one very important point, that negative Galleys is taken as diagnostic of a disease called autosclerosis. This is a very important point. Although this is not always true, but this is true for you, that negative Galleys is diagnostic of autosclerosis. Very important MCQ, very commonly asked. Now let me tell you something important here. See, so far we have talked about tuning fork test. What does tuning fork test? What is the information tuning fork has given us? Tuning fork test tells you whether there is a hearing loss or not. And if there is a hearing loss, is it CHL or SNHL? Is it right side or left side? So this is only talking about hearing loss. It does not tell you the cause of the hearing loss. It does not name the disease that is causing the hearing loss. We know this so far. But autosclerosis is the name of a disease. So negative Galleys is the only tuning fork finding that gives you a diagnosis, a name of a disease, autosclerosis. No other tuning fork finding of no other tuning fork test gives you a diagnosis, a name of a disease, except negative Galleys. That's why it's a important tuning fork test, right? So these are the main points about tuning fork, which is very, very important. Let's take 1 or 2 questions. Now this is question number 1, where right here has AC more than BC. Left ear also has AC more than BC. On the right ear, ABC is reduced, as you can see. Left ear also ABC is reduced, and Weber's is going to the left side. Now this question has finding of Renes, Weber's, Swaback's, all the three. And based on these three, what is the diagnosis or what is the problem? Which ear has what problem? See, if it is AC more than BC, or if it is reduced ABC means what? The only option if it is reduced ABC is SNHL. So this side ABC is reduced, this side has to be SNHL. Because and in SNHL you can get AC more than BC, false positive. This side is the same thing. The ABC is reduced, so this also has to be SNHL. And again you can get AC more than BC because false positive. So one thing is sure, that bilateral SNHL. And if it is bilateral SNHL, Weber's goes to which side? To the better side. So this is better ear, this is worse ear. So this is worse side, more hearing loss. This is better side, less hearing loss. So what does it tell us? It tells us that both side is SNHL, right side has more SNHL. It is worse compared to the left side. This is your answer. Bilateral SNHL, right side is more SNHL than the left side. Right? Very important. Now, second thing, if I ask you in this patient, what is the problem? You say bilateral SNHL, right side is more than the left side. If I do not give you ABC finding, suppose this is not given, okay, only rest of the thing is given. Same question, I have removed ABC. So now the question says that right side AC is more than BC, left side is also AC more than BC, Weber's is going to the left side. What is the problem now? What is the diagnosis now? If it is AC more than BC, both sides, there can be no conductive hearing loss. So conductive hearing loss is ruled out because AC more than BC cannot happen in CHL. In CHL, BC is more than AC in both the sides. And if it is lateralized Weber's, both cannot be normal. If both are normal, it is centralized. If it is lateralized, it has to be either CHL or SNHL. So there is a problem. It is not normal. And what is the problem? The problem cannot be CHL, so there is SNHL. Which side is SNHL? In SNHL, Weber's goes to the better side. So this side is SNHL. Confirmed. So this is confirmed. Right side is SNHL. This is your diagnosis, or this is your answer, the right side is SNHL. Okay, right side is SNHL. What about left side? If I ask you, you say that right side with this finding, right side is SNHL. What about left side? Now left can be SNHL, but less than the right side, less than this, or it can be normal also. So right side in this case can be one of the two. Now how do you know, is it this one or this one on the left side? Because right is confirmed, it is SNHL. And to find out this, you have to do Swaback's test. So this was a question asked in AIMS once, that they give you this kind of finding and they ask you what is the next best thing to do in this patient. The next best thing to do is Swaback's on the left side, because left side I am not sure it is SNHL or CHL, and this dilemma will be cleared by Swaback's test. So remember, now you notice how, where Swaback's is important, where it can be used. Okay, let us take a next example, second example. In this, the same example that we discussed, not the same, it is different actually. Right is AC more than BC, left is BC more than AC, and Weber's is going to the right side. ABC is not given, Swaback's is not given. Okay, if BC is more than AC, it is either CHL or dead ear, which is severe SNHL. Yes or no? So it is one of the two. If it is CHL, in CHL Weber's goes to which side? In CHL, Weber's goes to the same side. It should be like this. Is Weber's going to the same side? No, it is not. It is going to the opposite side. So CHL is ruled out because Weber's is going to the other side. So the only option left is dead ear. or severe SNHL. Because it's SNHL, severe, Weber's goes to the opposite. So left is severe SNHL. Okay? Or you can say false negative release. If you remember, in dead ear or severe SNHL, this negative is false negative. So this is what you can say, left side is false negative release or left is dead ear, severe SNHL, whatever is the question. What about right side? See, if right is normal, AC more than BC, it is either normal or SNHL less than this side. This is severe, so this has to be SNHL less than that. How do you break this dilemma? Is it normal or SNHL? Again, SWAB-X. So to know this, you again have to do SWAB-X test. Right? Again, they may ask you what is the next best thing to do in this patient. You have to do SWAB-X test on the right side this time. Right? These are the types of questions they may ask you in tuning fork. You have to practice a little bit and you get the hang of it. So this will complete all the important points about tuning fork test, which is